So we're going to shift gears a little bit, still talking about heart failure, but we're going to focus on more advanced heart failure patients, and specifically, what is considered too sick for a Mitraclip, who needs to be sent for an LVAD or transplant. I'll start by saying that there is really no consensus, and I certainly don't have an answer, but it's something that I've struggled with certainly my whole career. I think that sort of sick heart failure patient, is it risky? Should we do it? Should we send them straight for an LVAD? Should we listen for transplant? And I think that's something that we still discuss a lot today. My relationship with Mitraclip goes way back to the COAP study. As an early faculty member, I was the PI for the heart failure portion of it. And I remember thinking two things. One, this is never going to work, first of all, which, as Catherine alluded to, we were all blown away by the success of it. But also, two, this is not going to work for my patients, because my patients have advanced heart failure and they're too sick for this. And I think that's probably still one of the biggest barriers today to referral from heart failure doctors is, I don't know, this guy's pretty sick. I think he's not going to do well with a clip, or worst case scenario, when we put a clip in somebody with advanced heart failure, they're going to collapse hemodynamically and go into shock, end up on ECMO. And as a heart failure physician, that's one of the greatest fears that we have, is causing harm with this. And I think there is data that's going to be coming out on real world use of this, thousands and thousands of patients. And as many of you probably are aware, the real world use of this did not closely align with COAP. There's actually a lot of sick patients getting this device. So I think once that data is out, we'll know a little bit more about sort of what's too sick. Is there too sick for a valve or for clip? I'm going to do my best to give you my perspective on it, show you two very small studies in this type of a population. I'm also going to take a minute to educate you on what I consider an advanced heart failure patient, to give you some ideas of sort of what to look for when you're seeing these patients. But first is a case, and this is actually one of the first patients I took care of when I joined Piedmont. He was a pretty sick guy. He'd had a non-ischemic cardiomyopathy for quite some time. EF of about 25. You can see a little bit dilated, not horrible, 6.5 centimeters. Good stroke volume, but bad MR, bad diastology. And I remember being very concerned about this guy, and I sent him for a cardiopulmonary stress test. And you can see, and if you're not familiar with these values, really less than 14 is really concerning. So he was kind of borderline. But he became decompensated, and we ended up doing a right heart cath, and you can see, wow, like really low cardiac index, high wedge. And yes, we are eventually getting to a clip. This guy got put on milrinone, diuresed, spent 2 weeks in the hospital. We were thinking transplant LVAD, but on a repeat right heart cath, actually his numbers got a lot better, and he was weaned off and sent home. I'll tell you what happens to him towards the end of the talk. But as you can probably guess, he did get a mitral clip, and you'll get to see what happens to him. So as Catherine and everyone else has alluded to, functional MR is bad in heart failure with reduced ejection fraction. And it's important that you shift your thinking from, oh, this is just a side effect from a dilated ventricle, to actually this is contributing to the pathophysiology of this disease. And that's why these patients die. Volume loading of ventricle leads to dilation. Dilation leads to more functional MR. And as Catherine alluded to, this vicious cycle that leads to death. Now, we know also, though, that in the COAP study, actually we can help these patients. Significant reduction in mortality, all-cause mortality, quite significant, with a very low number needed to treat. 6 patients. The reduction in heart failure hospitalizations at 2 years, which was the primary endpoint, just tremendously reduced. And of course, 95% of people had really good results from the procedure itself. So, we can do the clip and we can make people feel better. We can actually make them live longer. But the question is, did COAP actually include what we consider advanced heart failure patients? Those patients that we worry about, that we're not real sure, maybe they need a transplant or an LVAD. Were these patients actually in the study? Well, you're probably all familiar with the inclusion criteria, and generally speaking, no, advanced heart failure patients were not the target of this study. But if you look at it, realistically, if I saw a patient with an EF of 20%, an end systolic dimension of 7 centimeters, by the way, heart failure people don't know what end-systolic dimension is. We don't even look at that. We look at end-diastolic dimension. So being the nerd that I am, I reverse engineered the end-systolic dimension to get an end-diastolic with fractional shortening. And that's about an 8-centimeter ventricle. And so if you have an EF of 20, an 8-centimeter ventricle, class 4 symptoms, and you've had a CRT and you're not responding to it anymore, that's about as advanced as you can get in my book, as I'll show you. Now, this was obviously a minority in the study. This was not the majority of the patients. The average EF was about 31% in the study. But in theory, you could have some pretty sick patients. So the best way that I can think to look at this is through the INTERMACS scoring system. And if you're not familiar with INTERMACS, it's basically a scoring system for advanced heart failure, not unlike the New York Heart Association classifications, but it's really specific for advanced heart failure patients, and we label them 1 through 7, and we use this pretty routinely, intermittently. It was actually made to track patients who end up going for an LVAD to show how sick they were before. But we use it clinically, and you can see it largely breaks down to level 3 and above, and level 4 through 7. Anyone level 3 or above is at least on inotropes. And I would submit to you that one conclusion I will make today that is not founded in any data is that if you have a patient who's dependent on inotropes, they should be evaluated for transplant LVAD prior to consideration for Mitraclip. That is clearly a patient whose prognosis is grim, typically 50% at 6 months, maybe a year. And so these patients, I'm not saying shouldn't get a clip, I'm saying they should be considered for these advanced therapies first, and if not a candidate, consider it. But the question that comes up and still remains for me is, what about these advanced heart failure patients that are not on inotropes? What does that look like? What's their prognosis? And would they benefit from going with a clip versus going for an LVAD or transplant? This is just a registry of what I would consider a contemporary INTERMACS 4 through 7 advanced heart failure patients. It's called METAMACS. And they literally just followed 161 patients who had really high risk features and followed them longitudinally to see what happened to them. You know, many of them went on to get an LVAD, transplant, and so forth. And this is just to give you an idea of what this population looks like and what their prognosis is. So this is what a heart failure community considered advanced heart failure patients who are not on inotropes. And you can see pretty low EF, pretty dilated. You can see resting hemodynamics here, in marginal index, high wedge, not a very good 6-minute walk test. And you can see here a cardiopulmonary stress test of 12 peak VO2, which, as I mentioned, less than 14, we really start to worry. So a pretty sick population. And you can see what that outcome looks like. About 34% either die, get a transplant or VAD at 1 year, and over half of them at 2 years. So this is the population that I think the question remains, would they be better served with an LVAD or transplant, or should they get a clip? And I'm going to try to show you a little bit about my thoughts on that. Clinically, and I'll run through this quickly, these are the things that raise red flags for me when I'm seeing a patient that they may have advanced heart failure and not on inotropes yet. The echo findings, we look at the stroke volume a lot, LVOT, VTI, when we're assessing these patients to see if there could be signs of low output. But when we see these things, particularly frequent hospitalizations, intolerance to GDMT, if they've had arrhythmias, and a big one is the CRT non-responder. Someone who actually got a CRT and did not respond to it, that's a high-risk population, or they did respond and no longer do. So with that population in mind, the question we ask ourselves every day when we're referring these patients, is it safe and effective, or should they go for an LVAD or transplant? So there's really no data on this. Again, I think when the real-world data comes out from the Mitraclip, hopefully that will shed some more light on it. But there were 2 very small studies that tried to kind of address this, both out of Heidelberg, Germany. I don't know what they're doing over there, but they're very aggressive with Mitraclip. This one was 9 patients that they actually had listed for heart transplant. So actually on the list, now not inotrope dependent with one exception. One patient was on some dobutamine. And they had bad MR. And they ended up doing a clip in these 9 patients. The question they really wanted to ask was, 1, do they feel better? And 2, do we kill them or not by inducing hemodynamic collapse? And you can see the baseline of these 17 patients, or 9 patients, excuse me, bad EF, dilated, very high pro-BNP, and some marginal hemodynamics here. And what they found was the sort of, again, very small study, underpowered, but when they compared it to a similar control group, their event-free survival after the clip was the same, if not a little bit better, than the other cohort that was matched with them. So they did not alter their clinical outcomes, long-term at least, in a bad way, meaning we didn't kill off these patients. In fact, maybe they did a little bit better. When they looked at individual outcomes, and this is confusing, so I'll just kind of jump to the conclusion of these graphs. The clip patients had improved New York Heart Association class. You can see almost a whole point. Obviously, the MR was much better. And importantly here, the cardiac index didn't change. If anything, maybe it went up a little higher in the clip group. The PA pressures did come down, which is actually a great thing for somebody waiting on a heart transplant. And the EF was unchanged, if not a little bit better in the clip group. And when you see unchanged, to me, that's actually a victory, because the biggest fear, as I've said, of heart failure doctors is putting a clip in and having them collapse hemodynamically. This study, at least in a very small population of transplant patients or listed patients, did not see that. And then the last one, again, very little data on this. This was an interesting study out of Heidelberg also, and they took patients who had gotten an LVAD and looked back at the ones that had a clip prior to their LVAD. And they found about 17 patients. They ended up comparing it to a cohort of about 20 others who got an LVAD without a clip. But you can see this was a really sick population. EF of 15, very dilated, very high proBNP, the index of less than 2, which is a big red flag for me, and a wedge of 27. This is a patient that would honestly scare me to do a clip on. I would say this patient probably needs an LVAD. And obviously these 17 patients did eventually get LVADs, but they all got a clip first. And the question is, was that safe? Was it effective? This is a busy slide. I'll just highlight, this is before the clip. The 17 patients all obviously went on to get an LVAD. You can see that, over time, the creatinines went up, the index went down, the patient's just doing worse. But I think the real take-home message is, was this immediate or was this delayed? What's the time point between getting a clip and needing an LVAD? And the median time between clip to LVAD was actually 1.5 years, which you could argue, well, they still needed it anyway, so maybe it was a waste of time. Or you could argue that 1.5 years without an LVAD is actually a victory. And I would argue that it is, because we know that when an LVAD goes in, the clock starts ticking. The average survival is 5 years. 5 years is not a lot. If you can get 2 years with a clip plus 5 years, you get the idea. Delaying transplant as well. Transplant, the average survival, 12 years, and the clock starts ticking once it goes in. If you have a 40-year-old patient with severe MR and you transplant them and they have 12 years, wouldn't you want to do something that could extend that for maybe 1 year, maybe 2 years? And that's sort of my take-home point from this, is that not only did these patients not collapse, even though they were quite sick beforehand, but actually they got 1.5 years on average before they ended up going for the LVAD. And importantly, after the LVAD, their event-free survival was no different from a group of 20 plus patients who did not get a clip but had severe MR. So the LVAD was still fine 1.5 years later. They just had more time. So taking it back to my patient, here's his data I mentioned to you already, and he came in really sick, but managed to get off of milrinone for a while, and we did actually send him for a Mitraclip, and he had 2 clips placed in June, 2 months later. Follow-up echo the next day, his EF was read as a little bit lower, trace MR, and his stroke volume was down by VTI method. It was about 20 before. My initial gut was, oh my God, I did the wrong thing. He's sicker, his heart's down, his stroke volume's down, and it was just beside myself. But then he got sent home and actually started doing okay. I saw him back a couple months later, and I was so freaked out that I did a right heart cath on him just to make sure he was okay. And look at these hemodynamics on his right heart cath. Wedge of 12, index of 2.7. Again, not on inotropes. A few months later, he was kind of complaining a little bit, so I did a cardiopulmonary stress test. Recall that it was much lower before. His peak VO2 was up considerably compared to the previous testing. Now, he did well. He did go on to get a transplant. And again, this is sort of my take-home point. He developed worsening heart failure just this past January and actually got transplanted about a month ago. So you could ask yourself, is that a failure of the clip, or is 612 days between a clip and a transplant a success story? I would argue that it's a success story for the reasons that I've labeled already. I think probably what we'll see is that a lot of patients get this clip and it buys time, and maybe some of them that are destined to evolve are going to anyway. But because there's such a time crunch on survival after an LVAD or transplant, extending life for 1 to 2 years without that surgery, I think, is something worth considering. All right, I don't have time for the take-home points, so I'll just fast forward through there. But I think the last one's probably the most important, especially in this population: multidisciplinary team approach. This is not a decision with these patients that any individual should make. We should be making them as a group, which we do here with our fantastic team. And with that, I will stop. Sorry if I went way long.